Hi, I'm Danica Koopmans.
And I'm Sharon Hughes-Geekie. We're your hosts of Docs of Vernon. This is an interview and podcast series designed to help you navigate the healthcare system and get to know the physicians that provide your care.
Topics include what the heck is a hospitalist, treating addictions, and alternatives to going to the ER, plus so many more.
This is your link to healthcare in your community.
There's a lot of things that people can do sort of to mitigate cancer risks. I mean, we live in an extremely sunny area, obviously. Sunscreen, not using tanning beds, all those sorts of things, because melanoma is on the rise. A lot of cancers are on the rise in part because of obesity as well. We're discovering that, uterine or endometrial cancer is on the rise, and that's an obesity-related one. Breast cancer, colon cancer, a lot of those things are related to lifestyle as well. Stuff happens, right?
Yeah.
We know lung cancers can also be caused by radon. And there's a lot of it in this area,
Wow.
in the mountain area. Like I live up in Middleton, and we had radon in our basement, so I put a radon fan in, to get your house tested. So you can't change certain things, but you can certainly make sure your lifestyle is healthy.
Yes, absolutely.
You can't change your genetics, right? But you can change how you live.
Can.
Because you don't want to see me if you can avoid it.
Even though you have a bright, smiling face.
But, nobody wants to be referred to the cancer center.
No.
We would rather have quiet days. Yes. We don't ever have quiet days, but we would appreciate quiet days sometimes. I mean, everybody talks about chemotherapy.
Yes.
Right. So, I mean, like the main treatments for cancer, once you have it, are surgery to remove it, or radiation to radiate it, or some form of what we call systemic therapy, which is basically treatment that goes throughout the body. And the poster child for that is chemotherapy. Mustard gas was kind of the first chemotherapy agent, I guess you could say, because one of the things it caused was low white blood cells. So in the 1930s or 40s, I believe, there was some research done looking at that, and it was realized that once they obviously made a more user-friendly version than gas, for the nitrogen mustards, they originally the original trials were applying it topically, but it was found that it worked on people with lymphoma, and that led to work on leukemia. So chemotherapy, is a broad term for a class of medications that basically interfere with how cells grow and divide. So chemotherapy is growing cell poison. We probably have 90 plus different chemotherapy drugs. We're using less of it now than we used to because we have other options, but most chemotherapy drugs interfere with DNA unwinding or duplication or cells splitting apart. They interfere with cells that are growing and dividing, which is why you get your side effects as well of hair loss, irritation of the mouth because the lining of the mouth, the gut is replaced regularly, and the bone marrow is always making blood. And nausea. I mean, chemotherapy has a well-deserved bad reputation of causing intensive nausea because those older drugs were incredibly nauseating. And we didn't have the new generations of anti-nausea medications we use until the late 1990s.
Wow.
Chemotherapy is really just one drug in our arsenal now that we're using more and more immunotherapy, which are drugs that try and get the immune system to do what it should have done to begin with. Like your immune system has one job in life, and that's to kill stuff it doesn't like. That's what it exists for.
It's true. It's actually one of my favorite systems.
It's a beautiful system. It's amazing. It's so fascinating. You get a pathogen into your body, a bacteria or whatever. It's recognized. It's attacked. It's killed. Little bits of it are handed to other cells in the immune system to create memory cells and create antibodies against it, so that if you run into it again, you have immediate immunity. And that's the principle behind immunization, is you give somebody exposure to something to do with an infection before they ever run into it. The polio vaccine, you have immunity to polio. So if you ever run into it, you should eliminate it before it kills you. The immune system is also supposed to kill off cells that have become abnormal. They're also supposed to kill themselves. So obviously, with cancer, they don't. So the immunotherapy agents that we're using now are basically trying to turn the immune system back on to recognize the cancer. And when that works, it's an incredibly powerful weapon, because you're using, instead of putting drugs into somebody that are killing cells or whatever, you're actually getting their own immune system to do the work for you.
So are these targeted? Like it's specific to each?
Some are kind of off the shelf, like most of the immunotherapy we use for lung cancer, for instance, are basically just antibodies that interfere with the recognition molecules, because my immune system is supposed to kill anything it doesn't like. So my normal cells want to make sure that they are recognized by the immune system, because otherwise you get autoimmune problems where your own immune system attacks, say, the lining of your intestine, and now you've got Crohn's or ulcerative colitis, or rheumatoid arthritis, where your immune system is destroying your joints. So there are checks and balances, which are called checkpoints, that are basically like handshakes between the immune system cells and your normal cells. And some cancers, because they are your cells, still have that ability. So they can suppress the immune response. So most of our immunotherapy drugs actually are antibodies that block the handshake. So now there's no recognition. So the side effects tend to be that we look out for the immune system attacking other things because it blocks handshakes everywhere. So and we can't give immunotherapy, for instance, to people with Crohn's or ulcerative colitis. But if you sort of take the brakes off the immune system, it sort of takes the camouflage netting off the cancer, if you will, and can allow that to be recognized. But there are also specific ones, like CAR T has been in the news, which is chimeric antigen receptor T cell therapy, or CAR T. And that's basically where you take somebody's T cells, their immune killer cells, and you program them to recognize a specific protein on, say, a lymphoma, and then you put them back in.
Wow.
And they attack anything that has that protein. And so those are extremely effective. Obviously, it's taking time to develop, all these different things, because, you have to make sure, for instance, that you aren't programming the T cell to recognize something that's also, say, on kidney.
Yes.
Because otherwise then you put those cells back in and they will attack something you didn't want attacked. So our systemic therapies may be a combination of chemotherapy and immunotherapy, or it may be immunotherapy by itself, or it may be hormonal treatment, or there may be targeted treatments. Like some lung cancers have very specific mutations. There are drugs that affect just the cells with that mutation. So a lot of our treatments, like when I started doing this, if you had a lung cancer, we just needed a little needle biopsy, just to give us a few cells to say, yeah, it's a lung cancer, and broadly what type of lung cancer it was. And now we need bigger pieces, because we have to have enough tissue to send for genetic testing and look for specific mutations and markers to see if it's going to respond to immunotherapy. So we need more tissue, which sometimes creates its own issues, because you've got somebody with a cancer and you'd love to start treating them, but you have to get a good tissue sample, because otherwise we're kind of dead in the water. It's frustrating, I think, what's frustrating for me, because I'm not the world's most patient person, but it's intensely frustrating for patients, because there's this process, right? They have a cough, they have a chest x-ray that's abnormal, they have a CT scan showing a mass, they end up getting sent for a biopsy, and they have to wait for that, or they go see thoracic surgery, and then we're determining, has the cancer spread or not, and we're determining what type of cancer it is, and all this takes time.
Yes. Yeah.
I have a ton of respect for family doctors, and because they basically have to be kind of experts in everything. But and without them, the system doesn't work. And I would lump NPs into that. So basically, primary care. Like family docs, nurse practitioners, whatever. You have to have that point of contact with the patient, so they can get their basic vaccinations. They can get lumps and bumps checked out. They can make sure that blood sugars aren't 32.
Yes.
Screening. Everything. Yeah, screening. All that. You need that contact. So.
Absolutely.
That was a really long answer to a question you didn't ask, wasn't it?
I had it in my notes. I don't know if this was just my generation, but I feel like we went through this season where it was like, well, I don't know, is cancer really, can we really not cure cancer? It's like, well, when you really get into what cancer is, it's pretty clear that it just continues to evolve and change, and we can't keep up with that evolution and change. You can't see the future of what these cells are going to do.
That's kind of the issue, is we always sort of talk about cancer as if it's some foreign thing, like it's a grenade fragment in your body that we need to do surgery and remove, but it's you. Yeah. They're your cells, and they've gone off the rails. And so how do we kill off your cells that are misbehaving without killing off a bunch of other ones that aren't?
Now, All that cancer talk has me hungry.
Ah,
Have you been baking recently?
I was, but I didn't bring any in, sorry.
So outside of medicine, Dr. Hardy actually bakes cakes.
I have a life, sort of.
He
yes.
does have somewhat of a life occasionally, and I know that you're very passionate about family and your children and your wife and enjoying things outside of medicine. I'm sure you learned that the hard way from dealing with people who go on these journeys. In all seriousness, cancer obviously is a very painful topic for many people, and I think, you know, as healthcare professionals, we do take that on, and often it does cause us to change how we show up and maybe how we live, knowing that there is another side to things, and life is finite.
Well, I'm not even super good at that myself. Like, I mean, separating, you know, work and outside of work. But yeah, the number of people that I've seen over the years who've said, you know, but I can't have cancer because I just retired. We were going to travel. And you know, I mean, like, so yeah, you can't take anything for granted. So yeah, you do need to enjoy your life outside of work, for sure.
Yeah.
I think your generation is better at that than my generation, certainly the older generation.
Yes.
You know, in terms of work-life balance.
At least fighting for work-life balance.
Well, I mean, burnout and mental health, I mean, they were things you didn't discuss. Like,
Yeah.
I mean, you know, when I was an intern and a resident, it was like, suck it up, you know, like having a hard time, suck it up.
Yeah.
That's changing, fortunately. I think, you know, we're getting better at recognizing when our colleagues are stressed and perhaps recognizing it ourselves, and there's really isn't as much stigma now.
Was there anything else you wanted to share with the audience before we head out?
I feel very fortunate to work here. I love Vernon. You know, people say, what are you going to do when you retire? Well, first they say, are you going to retire? It's like, well, God, I hope so.
You're not near to retirement.
No, not yet. I wouldn't mind skating back a little bit, but you know, no, I'm not near retiring. But it's like most people want to retire to this area. So I feel like when I retire, like, what do you mean, where am I going to go? I'm going to stay here. I'm going to enjoy this area. But we've got a really good team here. So, I mean, in terms of sort of the Docs of Vernon thing, I think if anybody is watching here, you know, we've got a really good team, a community, very supportive community here in Vernon. Like the support for the hospital and the hospital foundation has been amazing. I sit on the foundation board, and I'm just constantly in awe of how much the community pulls behind the healthcare here. So move to Vernon. It's, you know, if you're in healthcare, we need you.
Yes, I love that. For work-life balance.
Absolutely.
For us all. It's a
Yep.
win. Well, thank you so much. And stay tuned for our interview tomorrow, of course. And you know where all the links are to access. If you want to talk more oncology, we can have more of Dr. Hardy come in and answer more of your questions. So thank you so much and have a great day.